The other thing that this wonderful doctor brings to us in his expertise is the ability to do absolutely wonderful medico-legal assessments and reports. We are very, very proud to have him on board, and I'll hand over to you, sir, for this very interesting seminar. Thank you.
Thank you. Thanks for the introduction. I have been doing the lung cancers and thoracic malignancies for a long time. I did my fellowship based at the Guy's Hospital back in UK, and we used to have a lot of exposure to mesothelioma in the southeast London area. And since then, I've continued with these cancers. So I thought we'll just take it a different approach today to mesothelioma with a slight brief overview of where we are, what the basic pathophysiology in mesothelioma, and what is the current evidence, and where do we go on. I'm not gonna be because we can talk about immunotherapy and the immune system, and that can go on for hours. So I'm just taking a bit of approach where I've just got the targets, and then we'll work towards where we are, and there will be time for questions as well. So we will try and focus on a few things, just a brief outline of what the lung mesothelioma looks like, what the asbestos pathophysiology, what are the current options, and specifically looking at the immunotherapy for the future. As you know, mesothelioma has got a very strong association with asbestos. Asbestos is a set of 6 naturally occurring silicate, which goes from a very long to thin fibrous and composed of millions of microscopic fibrils as well. So it is a combination of a lot of different types and how the fibers are there. If you look at the pathophysiology of the mesothelioma, so you got your normal cells, which are your normal mesothelial cell, which lines the lining of the lungs. Once you get infiltrated by or you get exposed to the asbestos, these mesothelial cells will pick up asbestos fibers. The body feels that, okay, there is something wrong. Then they start to invade it, which is what the immune system gets activated. That's what the macrophages or the white cells are. Subsequently, it tries to sense that there's something not right there. So, and they keep recruiting more and more cells into it. So after the macrophages, the cytokines or the chemicals come in. After that one, these cells just keep accumulating. And over a period of time, if you do not get exposure to asbestos, this process stops there, and ultimately you will end up with what we call is the asbestos plaques. If you continue to have the ongoing exposure to asbestosis, this process just continues. You get more cells, more inflammatory cells, and ultimately you will develop a new blood vessels, and that's where it ultimately develop into what we call is a mesothelioma. So the process from a normal mesothelial cells to the inflammatory process to the inflammatory response process, depending upon the number of exposure, if somebody is in the field which get exposed daily basis, this can take 5 to 10 years. Somebody who does not have a lot of exposure, that process can take up to 5 years, or that process can even take up to 20 to 30 years time as well. So this is the basic physiology behind how the mesothelioma actually develops. Cancer Research UK, they did an audit back in 2022-2016, and they actually demonstrated that obviously the incidence in men is still increasing. There's a bit of plateau right at the end. Similarly, the incidence in females is just plateaued out, but if you look at the combination, it still has got an overall upward trend. It goes between the ages 50 to 49 seems to be the most common, and as you get older, there is still a low grade prevalence, but people as you get older are the people who had a lot of exposure, who had exposure long time ago, and it's taken 30 to 40 years to actually develop the mesothelioma. Mesothelioma is it's not just one cancer. I mean, now we actually know with the various clinical trials that the mesothelioma really makes a difference in terms of what you actually got. If you got a diffuse mesothelioma, then the 3 basic type that you actually worried about is the epithelioid, which has got a best outcome. Sarcomatoid mesothelioma, on the other hand, is a more aggressive outcome and tends to do worse. Similarly, you can have either epithelioid, you can have sarcomatoid, or something called have the biphasic. There are other two types of rare one, which is a well-differentiated papillary or adenomatous, which are rare but still well documented. How do we stage mesothelioma? We stage mesothelioma similar to any lung cancers, where basically you're invading the T1 is tumor, lymph node, and metastasis. The tumor is basically depends on the size along the lining of the lung, whether it involves one side, two sides, or it involves any of the organs. Lymph node is regional lymph node, which is close to it, or the regional or the lymph node, which is on the other side as well. Metastasis just meaning that it is actually spread beyond the lungs, or it is spread beyond the lining of the lungs. It could be brain, it could be liver. Brain metastasis is extremely rare, but seen commonly in 3% of the mesothelioma patients, whereas the other metastasis is between 5 and 10%. So how do we actually manage it? There's two different aspects of managing mesothelioma. One is to manage the symptoms. The symptoms are shortness of breath, which is the biggest and most common side effect that most people will have. They will present with the pleural fluid or fluid around the lining of the lungs. And how do we manage it? Either we manage it by just draining it. We put a tube into the lung, into that cavity, and we drain the fluid. Nowadays, we can actually put a permanent, in a permanent catheter which stays there, and that can be drained by the nurses at home. Or what we call is something called a thoracoscopy, where you basically, the surgeons go into the cavity, they inject something called as a talc, and then that can stick the two lining of the lung. So these are the pretty much the management. This is not dealing with mesothelioma. This is just dealing with the symptom, which is shortness of breath. So the options of treatment, I think when we look at mesothelioma, this is basically where we sit today. So you've got surgery in a limited or a very localized disease. Then there are other complicated surgery like extrapleural pneumonectomy, extrapleurectomy decortication, which is basically taking the pleura and the part of the lung. Then you've got the chemotherapy option, which has been there before with cisplatin or carboplatin pemetrexed, and then the newer changes, which is the immunotherapy. In the future times to come, there is actually an intermediate way, which is a combination of chemo immunotherapy, which is not far in the coming times as well. Surgery in mesothelioma does not have a randomized data. We do have data where the surgeons have data published on the individual case series, but there is no randomized trial. There's never been an evidence for a trimodality surgery, which is surgery, radiotherapy, and chemotherapy. It is usually a surgery which is considered in a very selected number of patients. It has to be done in a high volume center and a tertiary center who has been doing that one. And it really depends on the outcome, what you're actually trying to achieve, the morbidity, what's the quality of life going to be for the patient at the end of it. So it is extremely rare complication. It's a very extremely rare surgery, which is done in a very big centers, but it's not routinely offered to our patients. Radiotherapy is in the process where we find that the patients, we are unable to attain a control on mesothelioma by just chemotherapy or by drainage, etc. It is more to manage the symptoms. That could be a localized pain. That could be infiltration into the local muscles, etc. You could do their options are, we could potentially have radiotherapy to the areas where you drain the fluid so that the mesothelioma cells don't track. Radiotherapy could be a part of chemoradiotherapy, but how we actually do it is more in the palliative situation, and it is not something that you routinely offer these people. So the biggest change about 15 years ago came along with the chemotherapy, where they compared the chemotherapy with a platinum agent called cisplatin versus cisplatin pemetrexed. And it showed that for the first time that we could make people live longer, about more than a year. So the overall survival was around 12.1 months as compared to the single agent cisplatin, which was around 9.3 months. And that has been the standard of care until about 2 years, until about 18 to 2 years ago. People have been quite interested to see okay, what is a mesothelioma actually looks like in when you look at the various molecular alterations. So they've tried to figure out a lot of molecular profiling in these patients. So basically the two most common, the epithelioid and the sarcomatoid, whereas this is a biphasic where you got the component of both epithelioid and sarcomatoid, but you do have the epithelioid as the most common variety. Similarly, this is a biphasic where you find that the sarcomatoid is actually the most common. There are some individual bases. Sarcomatoid seems to be a lot more on the aggressive, so you do find that various molecular profiling is slightly higher. At this point, there are trials, but none of them seems to be a targetable mutations. As compared to previously, mesothelioma is not a benign tumor. There is a lot of molecular alteration which we have not yet managed to convert into a sequential treatment. As you can see, the most common tumor profiling, you've got ASS1 loss, BAP1 loss, CDNM mutations, PDL1 positive, mesothelin, NF2, PK383. So there's lots of options that potentially are available or will be available in the future. In the currently, we do have, or the one that has actually made the biggest difference is the PD1 or PD1 inhibitors, which is currently, which we're going to talk about in a minute. FAK inhibitors were a negative study and did not actually end up in the treatment. There are PK3 and AKT inhibitors which are currently available and in the trial phases as well. Platinum-based chemotherapy has been the standard of care along with what we call as the anti-angiogenesis agents, which has been on the trial but has not made to the front line yet. Okay, now we talk about how we actually, this is just this is the basis for most of the immunotherapy that we currently use. So you've got an dendritic cell and you've got the T cell. So T cell is actually one responsible for the immune system, and dendritic cells are the cell that pick up, okay, there is something not right, body has been exposed to a chemical, infection, inflammation. So they will bring what they think is actually foreign onto the T cells. Then T cells is a part of the body's immune system, which will actually stimulate the immune system. And that's where the body goes and fights the cancer cells. So there are two processes: dendritic cells, or the immune cells, which basically are the one that's activated upon exposure to anything, and then they bring it to the T cells. But to get to that exposure, you need these two cells will interact, and that's the interaction through what we call as a B7 CTLA4, and this is the target. This is the one of the part of the immune system, which is basically we are trying to block. And CTLA4 is a negative antibody, so we want to block this antibody so that the immune system can be stimulated. So this is an inhibitory signal which we are blocking. On the second cycle, we've got the interaction between the PD1 and PDL1, which is a stimulatory molecule, and that is and there are antibodies which actually there are antibodies in this pathway as well. So you've got anti-CTLA4 and anti-PDL1 antibodies, which has been the two most common antibody used in the immune system. We use in a different combination. Cancers like kidney cancers, melanomas, etc., we use the combination, whereas the cancers such as the lung cancer, there are lots of indication where we use these antibodies on its own as well. So just where we are in terms of the immune antibodies, it is, as you can see, immune antibodies are pretty much used in every cancer known, or most of the cancers known to us. It is growing. It started off with melanoma about 10 years ago, and now pretty much we use with most of the cancers, including triple negative breast cancer, gastric cancers, bowel cancers, etc. But these now, just what's happened to us in terms of the mesothelioma, we've been trying to target a different pathways along the way. Whereas this is the first exposure where the body is exposed to the antigen or the antigens or the asbestos fibers that you got, then you could potentially use radiotherapy, chemotherapy, T cell therapy. Once we activate the T cell or the immune system, then you got your T cell CTLA4 antibodies. Subsequent, as the immune system takes through this process, there are different options. You could do a local treatments, you could do the vaccines, or there are some antibodies which can be used as well. So as you can see, there is a lots and lots of process, which is lots of things and development in mesothelioma, which is happening. So the one study that I really want to talk about is, which has changed how we actually managed our patients currently in the current state in Australia. This is a phase 3 study, open label, where we use a combination of 2 immunotherapy for unresectable metastatic pleural mesothelioma. This was combined with a combination of a standard chemotherapy, which we showed before, with survival of around 12.3 months, versus the combination immunotherapy on its own. These people had unresectable mesothelioma, good performance status. They were well active. They had no prior chemotherapy, and they had about 600 patient association with it. And they were looking like overall survival is how long can we actually make them live, or how long we can actually make them the cancer under control. These are the graph, basically not expecting to, but as you can see, the red line on the top basically demonstrates that giving the combination immunotherapy clearly makes a big difference. We can clearly, there is a gap and there is a curves separating. At the end of 12 months, 68% of the people were alive giving them combination immunotherapy, as compared to 58% by just giving them chemotherapy. This difference continues to go up around 14% at 2 years and around 8% at 3 years. And as we've seen with the previous immunotherapy, the graph with immunotherapy continues to be flattened. And as you see at the bottom of this curve, the curve with the chemotherapy is starting to drop, whereas we see pretty much, as we all solid cancer that we've seen in the past, that people who do respond to immunotherapy and they do respond for a long time, their graph does not get stable. And it's quite likely that once these graphs get updated in the next 2 years, we might find that 15 to 20% of the people will achieve a long lasting response to the treatment. And for the first time, we would actually see in times to come that people on immunotherapy will be living longer, will be living with these cancers for a long time, as we've done in the past as well. Similarly, overall survival, median overall survival months was around 18.2 months. This graph has been separated between epithelioid versus the sarcomatoid, and the biggest difference came along the sarcomatoid malignancy. The more aggressive, the more immune system activation. As you can see, this is the plot. This is trying to say which people benefit. As you can see, all people, regardless of the age, male, female, ECOG performance status, 0, 1, previous smokers, epithelioid. The non-epithelioid or sarcomatoid, they derived the maximal benefit, but saying that one epithelioid still derived benefit out of it. PD-L1 checking the immune system status did not make a difference. However, everybody in this study did derive a response for it. This is another way. This is progression-free survival of 6.8 months versus chemotherapy. Similarly, overall response was around 39.6% versus 44%. As you can see, the people did respond for about 12 months as compared to 6.7 months with chemotherapy. This was another graph looking at the overall survival percentages. How many people discontinued? Median overall survival, there was about 25 people. Every treatment comes with the complications. The combination immunotherapy can give rise to adverse events, which is mostly immune-mediated side effects. So there was about 1 in 4 will actually stop the treatment. But as we've said before, people who actually stopped the treatment because of the immune-mediated side effects, they still continue to derive the response, as we've seen with the other tumors as well. So in terms of the summary, the 3 years survival shows it was 1.5 times that of the chemotherapy after minimum follow-up about 3 years and patient being off for about a year. There was a 25% decrease in the risk of death as compared to chemotherapy. Overall response was around 40% as compared to 44% with the chemotherapy. There was a different biomarkers used, and they found that 4 antibodies might be able to use, and they can be taken in the future trials to figure out who will respond better to the chemotherapy. So in summary, so my take on the current status of mesothelioma is that about 10 years ago, when we started training, we would struggle from the respiratory doctors even to get a referral as an oncologist to see mesothelioma patient, because they would actually tell them there's nothing anybody can actually do. You should be able to go home and get your financial affairs in order. From 2010 to 2022, where we're talking about people may actually have a long-lasting response to mesothelioma, is actually quite interesting. It is something that we've never seen before. It is something that we can offer people. Yes, we can't. Mesothelioma is one of the diseases. It is highly unlikely we'll be able to cure it, but I think we in most of these situations we can actually control the cancer, hold the cancer, and give them the long-lasting response. The more stronger sarcomatoid component that you have and who do not respond to the immunotherapy, yes, the prognosis still remains poor, but there is definitely choices, and immunotherapy is the first line of options. People who fail immunotherapy, they often go, and then second line option will still be chemotherapy. I think the management is very different as compared to lung cancer, because the mesothelioma is a three-dimensional disease. It is one of those cancers where the accurate volume is based because lining of the lungs is actually goes as with the curvature of the chest wall. So three-dimensional volumes is something which mesothelioma is what it is, and so sometimes the normal scans may not actually measure the response. Saying that one, I think it is one of those cancers which requires a combination or a multimodality treatment. You need your nursing support, you need your community nurses to manage your fluids, you need palliative care, you need oncologists, and you need the treatment. So I think it's one of those cancers where it requires a lot of people and requires a lot of support. The treatment choice currently is immunotherapy, and in times to come, there will be a combination chemo immunotherapy, which is not very far away from currently, and the trials have been completed, and we should have data within the next 12 months. So I thought I'll keep it very brief. I would be in time for some questions.
Thank you so much. That was fascinating, actually. I genuinely had no idea of how the different types of this disease react and all the different factors that you have to take into account. Wow. I hope that for those of you listening as case managers and lawyers with people, matters that you're carrying of this, lets you know that there really are some very interesting new developments coming very, very quickly in the way that this is managed with much better outcomes for people. That said, are there any questions people would like to ask of Dr. Dua? No.
Could I just ask a quick question? I'm a lawyer with Turks Legal. What's the shortest latency period you've seen in terms of exposure and an actual injury, mesothelioma arising?
It's about 10 to 12 years.
10 to 12, nothing shorter than 10?
I can't recall. I think the 10 to it's about 10 to 12 years is what I've actually seen. It is quite I'm saying that it could be possible. I think somebody who works in a profession and has got a lot of exposure, because if we did not have the awareness of the asbestos, I think, and we continue to have these exposures, I think we would be seeing a short latency period, because most things have changed and people are taking a bit more precautions, and the mask, I think the burden of exposure has gone down. So that is why I think it is still taking a bit longer.
That's interesting. Thank you.
People are saying thank you, and that the talk has been really good. So that's great. Grace, did you have a question you wanted to ask?
I was going to. Thanks, Michelle. Thank you, Doctor. That was very interesting. I'm a lawyer at Morris Blackburn. I was just wondering, on the graph with respect to gender-based diagnosis, it was interesting that there was a high amount of females being diagnosed under the age of 50. I know sometimes when we have younger female clients, the diagnosis stage is complex. Is there anything that you're finding that where it might be misdiagnosed as something else, or just complicating factors with respect to diagnosis of mesothelioma in younger women?
I think one of the things I didn't touch was the diagnosis of mesothelioma can be actually very complicated, in the sense, or it can take There could be the way people go to the GP saying, okay, I've got these issues with shortness of breath. And because if you not had a direct exposure, or the GP might, or any doctors might actually take a history, so you have had an exposure, they may not actually remember. I've had patients where the women who've been housewife and has been diagnosed with mesothelioma, although the husband never got diagnosed with mesothelioma. And the whole reason they actually got was because they were washing clothes of the husband, which had exposure to asbestos. So it just takes, because it has been strongly instigated in our head that obviously you got asbestos exposure, you get mesothelioma. People don't think about what are the other roots of the mesothelioma as well, because women might be involved with home renovation, etc. So because we're not thinking about it, because what the mind doesn't know, the eye doesn't see. So it's if obviously we're not thinking, and if you're not thinking that these people can also have a secondary or a passive exposure, we're not looking for mesothelioma, you're actually looking for lung cancer. And sometimes when you drain the fluid for the first time, depending on the technique, depending on the lab, they might just come back and say, oh, this is just atypical cell, and it might take 6 to 12 months for people to actually get a diagnosis. So until you don't look for it, you actually don't find it. So that's why in females, especially under 50, makes it much harder to actually diagnose them.
Interesting. Thank you.
Wow. Goodness me. Okay, look, thank you, everybody. If there's no more questions, we can wind up. Looking good. Doctor, that was fascinating. I'm so grateful that you made the time for that. I know that this seminar is going to be very well received by people and is going to get lots of views on our YouTube channel. Again, thank you for making time. Thank you to everyone for making your time to join us, and look forward to seeing you on the next one.
No, thank you so much.
Bye-bye.
Bye.
That was good.
Thank you.